Hi, and welcome to the Prostate Cancer Advocates Forum webinar on clinical trial E3805. This is the CHAARTED trial, which is chemo-hormonal therapy versus androgen ablation randomization trial for extensive disease and prostate cancer. This presentation was provided by Christopher Sweeney, and it was also presented at ASCO 2014 this year, just in the last few weeks. And the slide deck was set up for general distribution and sent out to Nicholas Vogelsang. Nicholas Vogelsang, in turn, forwarded me this trial information and the slide deck. I will go ahead and do a presentation right now briefly on the discussion of the CHAARTED trial, its significant results. First, evaluation of myself. I am Tony Crispino. I am a patient advocate and a long-term survivor of advanced locally metastatic prostate cancer. I today am a member of the Society of the American Society of Clinical Oncology, of the American Urological Association, and also of the Southwest Oncology Group. My role, again, in this trial is just to do an interpretation prior to the actual presentation that will be performed on June 18th at 7 p.m. Pacific Standard Time by Dr. Nicholas Vogelsang at the US2 Las Vegas chapter of Prostate Cancer Education and Support. A quick review of the history of hormone-sensitive metastatic prostate cancer. It's very important to note that in the 1940s, significant research, which eventually led to a Nobel Prize for Charles Huggins, was discovered in dogs that neutered dogs did not develop prostate cancer as frequently as unneutered dogs. That is the basis with which he eventually led himself into a Nobel Prize. And his research did discover that suppression of hormones or testosterone in the removed testes of these dogs resulted in the disease, both regression and less development of the disease itself. It was then in the 1960s with which it became more of a standard of care to which some patients would actually receive orchiectomy as part of their prostate cancer therapy in order to prevent the disease from continuing to progress or to get the disease cancer regression that was noted in the study by Huggins et al. Patients with higher burden of metastatic disease have shorter survival. This is very well confirmed. It's confirmed even today. The presence of visceral or bone involvement beyond the skeleton is associated with a poorer outcome, just simply put. The improvements in overall survival with metastatic castration resistance, what we're seeing today is that there are several agents, but at the time that this trial got started in 2006, docetaxel was approved for use in prostate cancer after the TAX-327 trial confirmed that there were several months of survival among certain classes of patients. What was not noted was what patients were responded better to docetaxel chemotherapy versus just androgen ablation, and there was no real statistical data that could have been used, and thus that brings us to this trial. The first thought, however, came on over to the thought that, as you can see by the chart, androgen deprivation therapy would first be regressed. It would shrink down with the addition of androgen deprivation therapy, and then it would reemerge stronger and less and more resistant. The red cells, as you can see there, were cells that were not responsive to the androgen deprivation alone. So what we are seeing here in this particular chart is that there are multiple types of patients that will fare well with androgen deprivation and some that will not fare well. And thus the hypothesis came on out, would this improve with adding the docetaxel at the time of starting androgen deprivation therapy for hormone naive, which means we don't know how well the patient's going to react to hormonal therapy, but we'll add the docetaxel with it anyway. And will that improve and prolong overall survival? Pardon me. The ECOG 3805 CHAARTED trial had the patient stratification on the left, the randomization, and then the arm A and arm B. Arm A being the docetaxel arm, dosed at 75 milligrams per body mass squared every 21 days for a maximum of 6 cycles. Arm B was androgen deprivation therapy alone, and in both arms, androgen deprivation therapy consisted of either a GnRH or LHRH agonist plus or minus bicalutamide. They will be evaluated every 3 weeks in the docetaxel arm, which is within characteristics and dosing of the docetaxel to verify blood toxicities, and at week 24, and then every 12 weeks thereafter. And the arm B, ADT, the standard 4-month dose, or 30 milligram of leucolide acetate, for example, was administered and then evaluated with each return for dosing. The follow-up was to go ahead and follow up progression and overall survival. And in the arm B, whether or not the patient would be randomized on over to docetaxel. I said randomized, I mean at the investigator's discretion to go ahead and start to issue upon the presence of visceral or continuing metastasis, disease progression. They would then at that time have the option for additional options such as docetaxel. The key eligibility criteria: metastatic prostate cancer must have been confirmed. Prior ADT up to 120 days prior to randomization, and it would go ahead and continue with adjuvant localized therapies, either radiation or whatnot, and no progression within 12 months of finish. ECOG toxicity of 0 to 2, and then the patient was otherwise healthy, had liver, bone marrow, renal, cardiac, pulmonary, and neurological functions that was suitable for docetaxel, and there had to be no prior docetaxel therapy. Study endpoints: the primary endpoint, overall survival. The secondary endpoints consisted of the rate of PSA below detectable, and detectable was considered at less than 0.2 nanogram per milliliter at 6 months and 12 months. The time to biochemical and radiographic symptomatic progression, and then the time to radiographic or symptomatic progression, and define adverse event profile and tolerability. How well were these patients doing? And then the quality of life until 12 months after randomization. Of course, in the first 12 months with the 6 cycles of docetaxel would be a little bit harsh, but then they would improve in time. The statistical design of the CHAARTED trial, starting from left to right. The original design of the was only going to be for high volume only, which multiple uveal metastatic men or visceral disease, and the sample size was initially slated at 568. The overall survival of these high volume patients was to be projected at 24 months, with a percentage of high volume being 100% in this trial. There were no low volume initially. However, that was changed. The first revision allowed for low volume, increased the trial size to 600, and a median overall survival of 24 and 48 months respectively, with a 50% of enrolled to be projected. This would be to increase and allow for more enrollment of the trial. However, the final design of the trial changed yet even further, and we got the statistical data in this here to go ahead and take a look at, and we'll go ahead and break those down as we go on through this presentation. All right, 790 men were accrued from July 2006 to November 2012. The initial note, again, 2004 was when the FDA approved Taxotere on patent, and then in 2010, Taxotere became off patent and became a generic as docetaxel. And so there was a significant play of that in this analysis as well. But the planned interim analysis at 53% of the information was achieved in October of 2013 with pre-specified criteria and significance and the release of that data. As of January 2014, median follow-up of 29 months, there were 136 deaths in the ADT alone arm and 101 deaths in the ADT plus docetaxel. The patient characteristics, the age at median in both arms significantly same. The range from 36 to 91 years old were in the criteria. The race is broken down accordingly, and the ECOG prostatic progression scores were noted as well. The patient characteristics, the number of high volume versus low volume, you can see there was a consistent high volume, more high volume than low volume, which was consistent with the change in the trial at a later date, which allowed the low volume to start to enter the trial versus the high volume alone. So there was an initial accrual in the higher volume. The Gleason score, 4 to 6, is important to note that this was probably all due to grade sensitivity to biopsy. There was from Gleason 7, 8 through 10, also broken down accordingly. There were some men which had such metastatic disease that Gleason was never determined, that prostate cancer was detected, and there was no biopsy performed to confirm the Gleason grade, or was not reported. The PSA median was approximately the same between the two categories. The range shows that there was inclusive of men with radical prostatectomy with very low PSAs, all the way on up to 8,500. Patient characteristics, no localized radiation therapy was most of the patients. Primary radiation was administered, and radical prostatectomy was administered. There was no data on one particular patient, don't know why. And then adjuvant ADT was applied to some of these patients, so long as it met the criteria within 120 days. The median time to start ADT was about a month. Then they would go ahead and be randomized at that particular point. They probably already started ADT, they started ADT first and then went into randomization within a month after starting ADT. There was some patients that had no ADT prior to randomization, and they were randomized right out of the gate, so that they were either in arm A or arm B as an initial first stroke treatment. The good news, primary endpoint, overall survival. From month 12 to 24, we started to see a separation in this trial, and then from ranging on out from month 36 through 60, the separation within there was consistent, that the overall median survival was about 13.6 months, rounded up 14 months for these patients. The causes of death were noted that there was about a 30%, 32% improvement from the docetaxel versus the control arm, and there was a death due to the treatment itself, and the docetaxel arm, none in the control arm. And then there were other known causes of death that were a little bit higher on over in the ADT alone arm versus the active arm. There's a significant differential between the high and low volume diseases that's worth noting. This chart here on the left shows that ADT plus docetaxel versus ADT alone in high volume disease showed a 17-month improvement, and in the low volume arm there was no goals met because they needed to go out 48 months. We are right now too short on that data to be able to report on the low volume, and that will be noted again later on here. But there is a significant difference that high volume men fared much better than the low volume men did. And again, with the 1.0 being the median outlie, the median between the two sides was realized in the dotted line. So favoring ADT to the left of that 1.0 arm, or favoring ADT to the right of that 1.0 arm, in all cases, the patients fell on the left side, and there was significant benefit, with the median being the benefit at the 0.6, and all of the statistics in this particular case favor docetaxel. Secondary endpoints also benefited docetaxel. The patients with an undetectable PSA at 6 months versus 12 months, significantly better in the docetaxel arm. And then the median time to follow up for castration-resistant prostate cancer was also favorable towards docetaxel. And the median time to symptomatic or radiographic detection was significantly better in the docetaxel side. The therapy beyond progression. Once progression took place in the patients in either arm, they were selected for docetaxel, which on protocol for prior to 2010, the patients would have been selected for docetaxel chemotherapy, and that's why there was a significant difference. Returning to docetaxel for ADT plus docetaxel from the group of the 397-49 were returned back to docetaxel chemotherapy, typically within the 75 milligram versus mass squared dosing, and typically in cycles of 6. Other chemotherapies in 2010, Jeptana was released, cabazitaxel that is, and cabazitaxel realized also a significant benefit for these patients. So there was more patients. If you count up, there was 92 versus 158 between the two forms of chemotherapy. Mitoxantrone and platinum were also chosen for patients to which there was no benefit from either of the two forms of treatment, and it was given palliatively for control of quality of life. Hormonal therapies as of 2010, we saw the introduction of abiraterone, 2012 enzalutamide, and ketoconazole had been there as a generic prior. There can be a lot of discussion about whether or not DES or estradiol, estrogenic treatments, leukenes, and other types of forms of controlling PSA that were out there, but that had no significant benefits within this trial, and we were not following them in this trial. Abiraterone acetate, being released in 2010, gave us the probably the biggest reason for the inclusion. Both of the drugs, AR, enzalutamide in 2012, which was released post-chemotherapy and is currently on target for use post-chemotherapy, but right now Medivation is currently applying to go ahead and give it pre-chemotherapy. But that's important to note in this trial because the ADT plus docetaxel arm would have most definitely been eligible for abiraterone or enzalutamide, whereas ADT alone arm, they were not eligible for enzalutamide until after the docetaxel, cabazitaxel, mitoxantrone. Immunotherapy, very similar, released in 2010 and gave us, 2012, and also gave us the significant understanding that stipulus T could help in these patients. They were at the investigator's discretion chosen for those therapy as well. Some patients also had the option of radiotherapy, either for treating the metastatic lesions within the skeletal events or in debulking within the main prostate area. Chemotherapy doses given, the cycles and the goal of this trial, 87.5% met the dosing requirements. Those that were stratified before that were modified and taken off, either for that there was no initial effect or the patients were not tolerating it well due to toxicity. The non-hematologic toxicities would be allergic reaction, fatigue, colitis, stomatitis, neuropathy, both motor and sensory. These were relatively low in the docetaxel arm. There was some significant inclusion in there that needed to be noted as well, and there was a sudden death that was experienced with the administration of docetaxel chemotherapy. The hematologic toxicities were very similar. Again, the statistics stayed somewhat the same. There was only one grade 5 patient, either hematologic or non-hematologic. The patient died due to the dosing of docetaxel. And there are different grades that were detected, with the most significant neutropenia or febrile neutropenia, which was relatively high, but only 16% and 12% respectively were realized during the trial. The conclusion of this trial was the combination of standard ADT and 6 cycles of docetaxel significantly improved overall survival compared to the standard ADT alone with men with hormone-sensitive prostate cancer. Important to note, there was a differential between high and low. As we see here, the 6 cycles of docetaxel, in addition to ADT, represents an appropriate option for men with metastatic prostate cancer presenting ADT who are suitable for docetaxel. They can tolerate it. They have the, as I noted earlier, they had the ability to tolerate it and had no other functions, testing negative and hematologic testing prior to the administration. The benefit in high volume metastasis was very clear and justified treatment now. This is the game changer. This is the one where we will see probably this be an option for men who are initially diagnosed with metastatic disease and shown with N1, M1, MX, or N2 presence of the disease, they should probably be considered for ADT plus chemotherapy. The data for the low volume men is still not there. We just don't have the data. There was a significant note that there can be a follow-up of additional 48 months may, in fact, improve our knowledge of the effectiveness of this treatment and therapy. A lot of competition within this has got to be put into note. There is abiraterone early on. There's enzalutamide early on. There's ARN-509, the completion of all of the AR drugs that would be used earlier. And whether or not these pathways may, in fact, also play a factor in improving with docetaxel is still remaining to be seen. We suspect that these trials will give us a more clear picture of that at that time. The acknowledgments, I want to thank Dr. Christopher Sweeney for his presentation and his work on this trial and presenting this slide deck on over to Nick Vogelfang over at the Southwest Oncology Group, and his sharing of this data with me to allow me to go ahead and do this presentation right here. And ECOG Akron, and very significantly Sanofi Aventis, keeping in mind that Sanofi Aventis was still on patent when this trial began in 2006, and in 2010 they stayed with it and followed up into the end of the trial. This was also heavily funded by the National Cancer Institute, and thanks to those people, but most importantly, big thanks to the patients and the families and the providers, the patients on trial. Brave guys doing a great thing, and I know we lost a lot of those guys, but we did, in fact, get some very, very excellent data to be used here. That now gives us a pretty good idea that chemotherapy prior to hormone therapy failing is probably more sensible for these types of patients. Presentation by Nick Vogelfang on June 18th. Please tune in with us. I can accept 25 people on that presentation, and I look forward to seeing all of you there. This concludes our webinar.